Good evening, everyone. Thank you for joining us for tonight's program, Understanding Colon Cancer, hosted by Astera Cancer Care and presented to you by the East Brunswick Public Library and its health initiative, Just for the Health of It. Tonight, we're joined by Dr. Aamer Farooq. He's a medical oncologist and hematologist. And just a little bio background for you. Dr. Aamer Farooq completed his residency at the University of Tennessee Health Science Center in Memphis and a fellowship in Hematology-Oncology at Roswell Park Cancer Institute. Prior to joining Astera Cancer Care in 2023, Dr. Farooq served as an attending physician with Florida Cancer Specialists. He has published his research in several peer-reviewed journals, the Annals of Thoracic Surgery, Journal of Thoracic Oncology, and Journal of Clinical Oncology. Dr. Farooq was named Best Hematologist Oncologist by AY Magazine and won the prestigious Tsuguo Naruke Award for a research project at World Lung Cancer Conference. Dr. Farooq is the ex-president of APPNA Hematology and Oncology chapter. I'm glad to present to you all Dr. Farooq. Thank you for being here, and thank you for agreeing to do this program with us for our community. And I'll give over the floor to you.
Thank you so much. I really appreciate this opportunity by East Brunswick Library to have this presentation. As mentioned, my name is Aamer Farooq. I'm an oncologist, hematologist at Astera Cancer Clinic. It's a multi-specialty oncology group with hematologist, medical oncologist, radiation oncologist with locations all over New Jersey. I'm going to present a topic, colon cancer. My goal is to make this a very simple presentation and easy to understand. We will just go ahead and start. So the topics we are going to discuss today, we are going to discuss about what colon cancer is, the colon cancer risk and prevention. We are going to talk about signs and symptoms of colon cancer. We will discuss about screenings for colon cancer, which is a very interesting topic, and further imaging if we have any positive screening. We will also talk about colon cancer treatment and the advances, more recent one, and the advances over the last few decades. And at the end, we will also discuss about colon cancer prognosis, and we will also touch a little bit on the topic of colon cancer polyps. So colon cancer or colorectal cancer is a cancer that affects the large intestine, and also rectum, which is the last part of colon. We also use the word colorectal just to combine both colon and rectum. It's a very common and lethal disease, but it's very treatable, especially if it's diagnosed in early stages. We will also discuss about some environmental and genetic risk factor which can influence colorectal cancer. So first of all, we'll talk about the symptoms of colon cancer. Sometimes it could be asymptomatic, but usually it causes some stomach pain. The pain could be diffuse, or it could be more localized depending on the location of the tumor. It can also change the bowel habits. It can cause sometimes nausea, vomiting. Sometimes it can cause constipation. It can cause constipation alternating with diarrhea. It can also change the texture or color of the bowel movements. Sometimes we can see blood in the stool, and sometimes the stool color and texture changes to like tarry black. Sometimes when patients are having bleeding from colon cancer, they can just feel weak and tired or short of breath on walking short distances. Again, that could be the early sign of colorectal cancer as well. We will talk about epidemiology, which is basically discussing the incidence of colon cancer. and also its distribution. So colorectal cancer is the third most diagnosed cancer in males. It's the second most cancer diagnosed in females. So incidence is a little bit higher in males than females. And even the mortality is higher in males than in females. And the incidence of colon cancer is approximately 33% higher in males and around 20% higher in African Americans than Caucasian Americans. So race is also kind of a risk factor. If we look at overall in the US, every year we have around 153,000 new cases of colorectal cancer. A little over 2/3 are cancer of the colon, and around 1/3 or 46,000 are cases of rectal cancer. But overall, incidence of colorectal cancer is slowly declining around 2% per year. If we look at the mortality of colorectal cancer, around 52,500 people die from colorectal cancer every year. And the mortality also is slowly decreasing in colorectal cancer. If we look at the distribution overall in the world, the highest incidence of this type of cancer is in Australia, New Zealand, Europe, and North America. And the incidence is relatively lower in Africa and in South Central Asia. These differences could be related with the diet or other environmental risk factors, also socioeconomic status, as well as lower rate of colorectal cancer screening in Asia and Africa compared to Western nations. So that could also be a little bit impacting the overall incidence. In the US, the risk of getting colon cancer in average risk male or female is around 4%. So 1 in 25 people will get colorectal cancer in their lifespan. If we compare it to breast cancer, that's around 1 in 8 female will get breast cancer in their lifespan. So incidence is a little bit lower than that cancer, just for a comparison. And if we look at the location of the cancer, so the colon kind of start when we eat. The food goes through the food pipe called esophagus. We have then stomach, and then we have several feet long small bowel, and in the right lower end of abdomen, small bowel meets the large bowel, and that's where colon starts. So the colon is like an inverted U-shaped structure. It goes up from the left side, from the right side, and then it goes this way. So we call it ascending colon, transverse colon, and then we call it descending colon when it goes down. So it's like inverted U-shaped structure, this colon. And the last part is called sigmoid, and after sigmoid, we have rectum, and then we have anal canal. So any cancer in this colorectal area is kind of considered in this colorectal cancer. And if we look at the incidence of which side, it's a little bit more. So there's a gradual shift toward the right side of the colon, or the proximal colon, which is ascending colon, compared to the left side. Part of the reason could be that the polyps in that area could be missed sometime in colonoscopy, because colonoscopy again is happening more on the left side. When we look at risk factors for colorectal cancer, in addition to sex and race, age is the biggest risk factor. And if we look at colon cancer incidence, the age kind of impact, especially in 40s and 50s, that's when the risk of colorectal cancer start increasing. And after 50, every passing decades, risk of colon cancer keep on increasing. The cancer can happen in younger age, but usually there are some genetic risk factor to it. And if we look at in the US, as I mentioned, the incidence of colorectal cancer is decreasing in, after 50 or 55, and it decreased around 11 to 20% between 1995 to 2019. But incidence is kind of slowly increasing in relatively younger population in 40s. And there could be several risk factors for that, genetic risk factor, change in the environment, change in the lifestyle. Overall, if we look at colorectal cancer in younger age, especially, genetics plays a big role, with around 35% of the cancer in 20s or 30s or 40s are associated with some or one or the other genetic disease, which we will talk about in a minute. If we look at screenings for colorectal cancer, colonoscopy is a big one, and one of the most important screening tool. Sigmoidoscopy, which kind of is like colonoscopy, but look at the last end, usually just at a rectum and sigmoid. That's another screening test. CT colonography is picking up a lot of pace over the last decade or so. President Obama famously had that CT colonography while he was in office. And then we have stool tests for blood. We also have a stool DNA test, and we'll also talk about some blood test. First of all, colonoscopy, which is, I would say, one of the most important screening tests. It's done by gastroenterologists as a field of medicine, and they start offering these colonoscopies. And basically, it's a tube with a camera toward the end of it, and after doing a proper preparation for this colonoscopy, they will basically look at the whole colon to examine and see if there's any polyp which they can remove. There are a lot of advantages of this test. The main advantage is that it can pick small polyps or large polyp, and they're able to remove it during the procedure. And these are the polyps which can become cancer down the road in 3 years, 5 years, 10 years. So the advantage of this test is that it's not just a screening test, but it could be a treatment as well, especially for small polyps, which they could be removed at the time of testing. The drawback with colonoscopy is that sometimes it can cause bleeding. There's a very tiny risk of tear inside colon during the procedure. But again, it's very, very rare. 1 in 1,000 people can have something serious with this tear or bleeding during colonoscopy. And then another disadvantage is that it does need a proper prep before that. And there are liquids, there are pills which gastroenterologists can prescribe before colonoscopy. Capsule endoscopy is another kind of colonoscopy. It's not really colonoscopy. It's something to look more at small bowel and also large bowel in patients, especially if they're having any bleeding, or if there is a GI bleeding going on and we cannot find where the bleeding is in upper and lower endoscopies, or with EGD and colonoscopy. Sometimes we have gastroenterologists give patient a capsule with a camera which goes through that small bowel where none of the other scopes can reach to see if any source of bleeding or any malignancy or polyp could be found in those areas. And sigmoidoscopy, as I mentioned, is kind of colonoscopy, but just for the last part of colon, rectum, and sigmoid. CT colonography is a relatively newer test, which is another great option in patients who are not interested in doing colonoscopy. This can look for cancer and also can look for polyps. As far as prep is concerned, it also needs prep, just like colonoscopy, because to have this testing in a more useful way, so it can give all the information, it's important to have the clean colon. And just like I mentioned, only it can tell us about polyps and cancer and masses, but it does not need all the medication which you usually need to relax the colon during colonoscopy. So that's kind of an advantage of it. The drawback, on the other hand, is that if the polyp is found, or if the cancer is found, you will still need a colonoscopy after that to remove those polyps, or to confirm the cancer, or to do biopsy. And another disadvantage is that it's an imaging test. It's like a CAT scan. So basically, a patient is exposed to some radiation. It's relatively more expensive because the cost of colonoscopy is going down. But this being a relatively new test, it's still a little bit more expensive, and sometimes insurance doesn't cover. I'll probably take colonoscopy over this. Then there are some stool tests for blood. The oldest one is just a regular stool test to look for blood. The benefit this one has is that it's easy to do. You just give a small sample of bowel movement, and it can kind of give us an idea to see if there's any blood or not. The drawback it has is that it's not very sensitive or specific, which means we could have a lot of false positives and we could have a lot of false negatives. So if you have hemorrhoid, that could impact it. If you have any injury to the colon, that could make it look positive. On the other hand, sometimes if you have a polyp or colon cancer, and it is not actively bleeding at the time of testing, it could easily miss it and can give us a false sense of security. But a year later, 2 years later, we could find a polyp or cancer which was not picked up by this test. And another drawback is that if it's positive, basically you need colonoscopy to confirm if there's any polyp or cancer, or if any polyp need to be removed. Stool DNA test is another newer test, and pretty famous nowadays because there's a lot of commercials about it. So it's Cologuard test. So in addition to testing for blood, this one will give us some more information. It's like a DNA test which will check for some specific genetic marker of cancer in the stools. So basically, you get a prescription from your doctor, and then you get a special kit and with instructions, and it usually need a whole bowel movement, and then shipped to the address, and then you get the results. So there are some advantages to this that it does not need that prep which you normally need before colonoscopy or CT colonography. And if the cancer is present or the polyp is present, it's a little bit better than the regular stool test for blood, which we just discussed before that, because it has less false positive or less false negative tests. But the main disadvantage is that again, it's a unpleasant way of doing this test. And another one is that if it's positive, then you're still going to need colonoscopy to remove polyp or to confirm if there's any polyp or bleeding or colon cancer. So colonoscopy is always kind of winner. So how do we choose which test to have? So it's kind of a lot of discussion between patients and their primary care doctor and their gastroenterologist to look at what particular test a patient is interested. So nowadays we do something we call a shared decision making, where we discuss options with the patients and kind of get their input to see what they would prefer. Sometimes some doctor like to mix and match. They will do like a Cologuard test with the sigmoidoscopy. CT colonography is not happening that much as we thought 10, 15 years ago when it was kind of new. I think it's colonoscopy still is something which is one of the best tests, and the GI doctor like those too, because not only it will give us screening information, but also it will be helpful for the treatment. As far as blood tests are concerned, there's a lot of development in this particular field, but we don't have any test which is proven to be done for these cancer. Every few years there's talk about this technology or that technology which will figure out all cancers in one blood test, but those things are still kind of in the process of research and clinical trials. CEA is a blood test which we normally use in patients who have a diagnosis of colon cancer. Or if we are having an abnormal imaging where it looks like colorectal cancer. And then if we have a cancer patient who we are treating and we want to see the response of treatment, but we really don't want usually to use this test just for screening. A lot of time we get like this mild elevation of CEA, and sometimes if you have history of smoking, the CEA could be a little bit higher than normal. And sometimes there are some infection masses which can cause mild elevation too. CEA could be elevated in some other cancers as well. So as an oncologist, we don't like CEA as a blood test for screening for colorectal cancer, because a lot of time it can cause some unnecessary anxiety and stress. So who should be screened for colon cancer? So starting 45, at age 45, used to be 50. But now, starting at age 45, everyone with average risk, male or female, should consider having a colonoscopy, especially if there's no other risk factor or no family history. Um, People who have increased risk factor due to different reasons, which we're going to talk about in a little bit, they can consider doing screening earlier than 45. And these risk factors include like a strong family history of colorectal cancer, history of exposure to radiation due to some other cancer in the past, familial genetic syndromes, which we'll talk about in a second. And also, if you have inflammatory bowel disease like Crohn's disease or ulcerative colitis, the risk of colorectal cancer is much higher. So those people start getting screening sooner by their gastroenterologist. When can we stop screening? So it kind of depends. Sometimes at 75, but if we have a very good healthy 75 with some symptoms, we can consider screening for them. But at age 85, for sure, after that, we don't do screening. But if you have symptoms or signs of cancer at any age, we offer colonoscopy. How often I should get screened? That's another important question. As I mentioned, if you are going for colonoscopy, first of all, you have to pick which test you like. If you go with colonoscopy, usually once you have colonoscopy, and if it is negative, the next one could be done in 10 years unless they have a polyp. And depending on what kind of polyp they have, they could repeat it in 3 years or 5 years. But it's done every 10 years, provided it's negative. CT colonography is done every 5 years. Stool test could be done once a year. Sigmoidoscopy, which is like a partial colonoscopy, mostly looking at rectum and sigmoid, could be done every 5 to 10 years. Stool DNA test, that Cologuard test, should be done every 3 years. But again, we don't know a whole lot about this test, and some people are trying to do it every year as well. Who need colonoscopy? Well, again, as a screening, everyone starting 45 or earlier if you have other risk factors. On the other hand, if you have blood in your bowel movement, then screening doesn't matter. Then you need colonoscopy or endoscopy, depending on what kind of blood is in the stools. If you have change in bowel habits like constipation alternating with diarrhea, especially with the weight loss, you need colonoscopy. Then if you have anemia, especially iron deficiency anemia, you feel tired, and we cannot find any other reason for anemia or iron deficiency or any other obvious source of bleeding, in those patients, we offer them a GI workup, including endoscopy and colonoscopy. If you have some non-specific abdominal pain, rectal pain, colonoscopy is another, at the time it's usually recommended. Or if you have any of the other abnormal tests like stool for blood, DNA, or CT colonography, if they are abnormal, then you're going to need a colonoscopy to see if you have polyp or cancer. Or if you have a history of colon cancer before or polyps removed before, then those patients will need a periodic colonoscopy. For example, after colon cancer surgery, usually we do first colonoscopy within a year. And if it's negative, then we repeat in 3 years. If it shows some polyp, we repeat it in 1 year. So that's kind of a different scenario where you need more often colonoscopy, not like screening colonoscopies. So we'll talk about some factors that can influence the screening. Screening is a very important topic. So I have a few extra slides for this. So there are some familial conditions where the screening could be done more often or start at a sooner age. We have hereditary colorectal syndrome. We have familial adenomatous polyposis syndrome, Lynch syndrome. If you have family history or someone in the family had colorectal cancer, if they have been tested positive for this, so we can do blood work even in patients who don't have cancer to see if they carry any of these genes. There are some other relatively less common genes like APC, BRCA, PALB2, TP53, so they can also contribute increased risk, and we can probably need colonoscopy sooner and more often. Another important risk factor is personal or family history of colorectal cancer syndrome, as I mentioned. If you have ulcerative colitis or Crohn's disease, the risk is 5 to 15-fold higher. History of abdominal radiation or cystic fibrosis, the risk is much higher. But if there's no risk, then starting at 45, we should consider starting colonoscopies. And we discussed about age and race, and these factors can impact how serious we should take this colonoscopy. Then there are some other medical conditions like acromegaly. It's a growth hormone abnormality. The risk of colorectal cancer is higher. The screening could start sooner. If you have a history of kidney transplant, if you're on immunosuppressive therapies, your risk is higher than average population. So you should discuss with your primary care doctor or gastroenterologist when to start scopes. Some other common risk factors like obesity, having hyperlipidemia, that can increase risk around 1.2-fold. Diabetes, especially insulin-resistant diabetes, increases the risk around 1.4-fold compared to normal population. Red and processed meat can increase risk. Tobacco is also one of the risk factors, not like lung cancer, but even in colorectal cancer, it can increase incidence and mortality with colorectal cancer. Excessive alcohol consumption increases risk around 1.2 times compared to those who are not having any excessive alcohol use. Use of androgen deprivation therapy. Sometimes we use these treatments for patients with breast cancer or prostate cancer. There is some data which shows that these treatments can increase risk by 1.3-fold for colorectal cancer. So the screening become more important. If you have history of gallbladder surgery in the past, there is some data which shows that in those patients, the risk is around 1.16 times compared to normal population. And there are things which we can do to reduce our risk of colorectal cancer. More exercise and physical activity have been shown to reduce the risk of colorectal cancer by around 27%. There is a study I looked at. Then diet can impact the risk for colorectal cancer. We can have a more fiber diet that can reduce the risk. Some people like to take some extra supplements, and there is some data on those supplements. For example, I was looking at vitamin B6, which is pyridoxine. There is some data that this can reduce the risk of colorectal cancer. Calcium, dairy products, vitamin D. There are some prospective trials which has shown, again, minimal, not a whole lot. It's not like we start taking calcium, we're not going to get colorectal cancer, but it does have some protective role. Magnesium is another supplement which some people use, and there is some data that in Europe, it reduced risk by almost 40% in females. Garlic in the food also have some protective role against colorectal cancer. More fish consumptions, omega-3 fatty acids or fish oils have also some protective role in observational studies in colorectal cancer. There is some data on coffee intake also, but again, data is conflicting. Some of the studies showed benefit at tiny mining, and some of them did not. Aspirin and NSAID, especially aspirin is a big one. There have been multiple studies that low-dose aspirin can reduce the risk of developing polyps, adenomas, or colorectal cancer. And some oncologists actually, after their patients finish chemotherapy for colorectal cancer, offer them just a low-dose baby aspirin, especially if they don't have any other contraindications to reduce their risk of developing polyps and colorectal cancer. Then there are some other medications or chemopreventions like anti-inflammatory drugs like Sulindac with the DFMO. But again, the side effect of gastritis is too much that is not worth it, especially with this one. But baby aspirin, on the other hand, is usually more tolerable. Hormone therapy in females, some European studies have shown some reduced risk of colorectal cancer. Statins, which we use for hyperlipidemia, also have some protective role. And then vitamin E, antioxidant, have been studied, but the data is conflicting. We don't have any clear answer to that. Bisphosphonate, which is used in the US for osteoporosis treatment, have shown around 11% reduction, a little bit of a reduction in the risk of colorectal cancer. Angiotensin 2 inhibitor like losartan, this is a blood pressure medicine, also have been seen in some observational studies that it can reduce the risk of colorectal cancer by a tiny margin. If we look at diagnosis and staging, again, diagnosis is done by colonoscopy, as we mentioned before. If someone is diagnosed, then usually we do further testing like tumor markers like CEA. We do some imaging studies like CAT scan and PET scan to know more about staging of the cancer. There's a test called EUS, or endoscopic ultrasound, which is like a endoscopy with an ultrasound to it, where they can give us some more information about staging. It's done by gastroenterologist. And then we also offer, if they have any family history, or depending on which age they're diagnosed with colorectal cancer, we also offer them some genetic tests like InVite, or those blood tests to see if they have any of the 84 genetic markers, which can increase the risk of colorectal cancer. A busy slide for staging, but I'll just leave that one. How is colon cancer treated? Surgery is the main treatment if it's diagnosed in early stage. Some patients after surgery will need chemotherapy, and especially if cancer is not progressed to stage 4. On the other hand, if it is stage 4, then we have some other immunotherapies or targeted therapies, which I will discuss. And if we look at any particular stage, so if you have just polyp, then just having an endoscopic resection could be the end of it, and you will need a follow-up colonoscopy in a year or 3 years based on what kind of polyp they found. And then when we look at the staging of the cancer, we use this staging system called TNM, or T stands for tumor size, tumor depth, N stands for lymph nodes, and M stands for metastasis, if cancer is spread somewhere or not. So colon kind of has 4 layers. So depending on which layer, how deep the tumor is going, we divide them into T1, T2, and T3, depending on, it's not just the size, but how deep the tumor is. So if it is T1, T2, or T3 colorectal cancer, surgery could be the end of it. And after that, you may not need any treatment. If patient have T3 or T4 disease, which means it's going to the 3rd or 4th layer, and it has some high risk features, then in those situations, in addition to surgery, usually as a medical oncologist, we offer around 3 to 6 months of chemotherapy. And if the lymph nodes are involved, N1 is a lymph node. So if the lymph nodes are involved at the time of surgery, then in addition to surgery, patients usually need 3 to 6 months of chemotherapy. It used to be 6 months, but it's happening more and more 3 months now, especially with the oral version of a backbone chemotherapy in colon cancer, what we call 5-FU. So it used to be IV, and now they made a pill in Germany with the name Xeloda, which could be as effective or maybe a little bit more effective than the IV version. So it's a pill which we combine with another drug called oxaliplatin, and most patients can just do 3 months instead of 6 months, depending on some other risk factors. If it is stage 4, or what we call M1 disease, then it's a little bit different. It depends how extensive the metastases are and where those metastases are. We still go for curative treatment options. So for example, you could have a colon cancer with one spot in the brain, and we try to cure it to see if we can do a resection of the tumor in the brain, or if it is spread to 1 or 2 or 3 areas in the liver, in addition to your colon cancer, it's still potentially curable. Not every cancer in stage 4 has benefit of doing these more extensive surgeries, but colorectal cancer is different. More and more studies are showing that being more aggressive in stage 4 colorectal cancer, if we don't have like 100 mets, if we have like 1, 2, 3 mets, depending on the location of the tumor, the data shows that more and more patients could be cured with more aggressive approaches with chemotherapy in combination with surgery. Sometimes in patients, especially in rectal cancer, more and more studies are showing that doing some chemotherapy with or without radiation therapy after surgery could be a better approach instead of doing surgery upfront, because there are some very important muscle in the anal sphincter And if we lose them, then we end up needing colostomy. So we try to shrink the tumor, especially in the rectum area, as much as we can with the chemotherapy, with or without radiation therapy, depending on the response to chemotherapy, and then go for surgery when the tumor is smaller, so we can save our anal sphincter and we don't end up with colostomy. And more recently, we have seen with some special type of rectal cancer, if they have something we call MSI high or microsatellite instability high markers, with that particular tumor, the studies are showing that instead of chemotherapy, if we use immunotherapy, like Yervoy and Opdivo, you might have seen the TV commercial for Keytruda, doing upfront 3 months of treatment with immunotherapy, or a few months of treatment with immunotherapy, and then going for surgery. And a lot of patients at the time of surgery have no cancer left behind, because those particular patients with that particular marker could have amazing response to the immunotherapies. I think lately it's been in CNN and other news networks as well. So again, a slide on different treatment options. Again, it used to be just chemotherapy a couple of decades ago, but now it's more and more targeted therapies, biological agents, and what we call, we do this next-gen sequencing panels on tumors. So it's kind of more personalized medicine instead of using the same drugs for every patient. But again, chemo is still an important part of colon cancer treatment. The main drug or the backbone of colorectal cancer treatment is 5-FU, which is also now available in the form of a pill form, Xeloda. A lot of benefit come from that, especially if it's early stage where we are doing 3 months of chemotherapy after surgery. Oxaliplatin is the second most important drug, which usually we combine with Xeloda or 5-FU for 3 months to kill any micrometastasis after stage 1, stage 2 or 3 surgery. We usually use that as adjuvant treatment, what we call it, after surgery, to improve chances of cure. There are a couple of other chemo drugs like irinotecan and Lonsurf, which are also used more in the stage 4 settings. And then, all other treatments I mentioned over here are basically targeted therapies, or what we call biological agents. We have VEGF inhibitor like Avastin, we have EGFR inhibitor like Vactibux. We usually have this PD-L1 drugs like Keytruda. We have Yervoy and other immunotherapy. We have these TKIs, what we call tyrosine kinase inhibitors. These are pills which we use in colorectal cancer. We have anti-RK fusion pill, which is kind of a drug which works in every cancer as long as you have that mutation. We have HER2 target directed therapies. If you have a BRAF mutation so basically cancer tissue, especially in stage 4 cancer, is tested through this NGS panels, where it can basically explore all the DNA and try to find any mutations available, and based on that we can pick a drug. We have RET fusion, and we have a special drug for that if you have that. And again, a lot of those drugs are used in advanced cancer. Again, usually patients have this question: if I'm diagnosed with cancer, what happens after that? Most patients after surgery will not require colostomy, especially if it's colon cancer. And some patients, especially if it's rectal cancer, may require temporary colostomy or ileostomy, especially if it's early stage cancer. Few patients may require a permanent colostomy. For example, if the anal sphincter could not be saved in early stage rectal cancer, or if they have obstruction or blockage in a way where they need to have a bypass to able to have chemotherapy. So sometimes patient will need ileostomy or colostomy bag, but not everyone. Majority of the patient in early stage cancer, stage 1, 2, 3, can have surgery and primary anastomosis, where they don't have to deal with ileostomy or colostomy. But again, it depends on the site of the tumor. The surgeon will decide if you need temporary or permanent colostomy. After you finish treatment or surgery, especially if it's stage 1, 2, or 3 cancer, usually we have what we call surveillance. So we do observation, especially for first 5 years. We have a blood test called CEA, which we use every 3 months, depending on the stage of the cancer. We do periodic CT scans to make sure that we don't see any evidence of cancer coming back, because despite doing surgery or chemotherapy, there's always a small risk depending on the type of the cancer at the time of diagnosis. So we have to monitor it to make sure it doesn't come back. And if it come back, we can catch it sooner. There's a new technology, Natera testing. It tests for circulating DNA markers of the colorectal cancer. It can pick cancer sometimes sooner than CT scan or sooner than the CA. So in patients with high-risk colorectal cancer after their surgery or curative intent surgery, and after finishing chemotherapy, we monitor them with this blood marker. And we also educate our patients, because cancer is a stressful disease, how to work on their mood, their stress level, their sex life. We educate them on eating habits, exercise, and other risk factors after they finish treatment. So basically, medical oncologists kind of become your primary care doctor for a little bit after cancer diagnosis, especially if it's removed with the surgery. But if it's stage 4, then usually we are more involved. Mortality, we talked about, colorectal cancer mortality, around 52,000 people die from colorectal cancer in the US. The survival rate in the US is much better compared to most of other countries because of our technologies and advancement in the healthcare and I think availability of healthcare to most of the patients. Couple of slides on the colon polyp. So again, there are different kind of polyps which could develop. Usually, any cancer start from one cell where you develop a mutation, and the cells kind of goes out of control of your own body, and it starts growing. In colon case, it could be the similar thing where it can become polyp. Not every polyp turn into cancer. There are different types of polyps. Some of them have a high risk than others. But if you have a polyp, basically you need to have colonoscopy and have it removed. The colon polyp can cause colon cancer-like symptoms. They can cause bleeding or alter, bowel habits, but a lot of time they are asymptomatic. Majority of the time, when you start doing those colonoscopies, your GI doctors can remove them at the time of testing. And if you have a polyp removed, you will need to have a very close relationship with your gastroenterologist because they will be doing colonoscopy more often, depending on how many polyps they see. Sometimes they refer patient to medical oncologist, especially if it has some signs of cancer, to see if patient need any imaging, or if they have any family history of colorectal cancer, to see if they need any genetic testing. So as a medical oncologist, sometimes we get involved in patients' care after their gastroenterologist have removed their polyps. Can they be prevented? Again, there are some genetic risk factor. There are some acquired risk factor which can increase our risk of colorectal cancer. There's some studies which have shown that the diet does impact that. Diet high in fruits, vegetables, fibers, and low in fat can reduce your risk of colon polyps. Losing weight, doing more exercise has some impact as well. If you don't smoke, that's a good thing. And again, excessive amount of alcohol can increase the risk of polyps as well. Well, thank you so much. I think that's the end of it.
All right. Okay, thank you. And now we're going to move over to Q&A session. So everyone, if you have a question for Dr. Farooq about colon cancer and his presentation, you can go ahead and drop your question in the chat. Just go to the chat feature and I will just wait for a moment until they start coming in, and then we'll go through those with Dr. Farooq for about 15 minutes.
Sure.
Okay. Okay, and it looks like we have a couple of questions already. I'll go ahead and read the first one to you, Dr. Farooq, and then you can go ahead and answer. So first question coming in says, do you recommend your clients to exercise during chemo radiation treatment?
Yes. So again, chemo and radiation could be challenging. When you're going through chemotherapy, you could have some side effects like fatigue and numbness or neuropathy. But the issue is that if we don't do exercise or if we don't do, any activity, the symptoms could be worse, and it can cause more anxiety, stress, depression. So more and more studies are showing that the sooner we start activity, even in patients who are sick in the hospital, we try to start doing physical therapy on them from very first day they can, because it can reduce their hospital visit by half. So the same thing with the chemoradiation. I have seen patients who stay active, they tolerate chemoradiation better compared to people who are, not very active.
Okay, and the next question is, did you say magnesium may be beneficial?
Magnesium may be beneficial, but again, the benefit is just tiny money. So magnesium can cause diarrhea. So if I go to, Costco and pick up some magnesium for myself, and I start having diarrhea and, become dehydrated, then you look at the risk for it and you will say that the risk is more than benefit. So I would say that, beside baby aspirin, the other, things which we mentioned, the risk is the benefit is very marginal, but the side effects could be real, especially with magnesium. But again, I put that in the slide just for education, that it does have, some benefit on colorectal cancer. But again, it has some side effects. If you start taking magnesium by itself, it causes a lot of diarrhea.
Okay, and I saw a general question about whether everyone who attended will receive a recording of this program. And I just want to let you all know that we are recording this program. We will post it up on our YouTube channel, the East Brunswick Public Library's YouTube channel. I can also go ahead and send you all a link to that once it's ready. It may take some time, but you will all be able to see that just to review it. And let's see, another question for Dr. Farooq says, what exercises are best for these clients?
So again, for a rectal cancer, when we are trying to preserve the anal sphincter and to make sure that we have a good control of bowel habits, the Kegel exercises are helpful for sphincter muscle as well, for anal sphincter muscle. And again, as far as activity is concerned, just walking or cardio or normal physical exercise is as good. You don't need to go for weightlifting when you're going through chemoradiation, because it could be very challenging, especially when you're tired and fatigued. So any activity is better than not being active during the treatments.
Okay, and I think that does answer. There was another question very similar. It said, are there exercises to strengthen the anal sphincter? So I think that what you just answered, Dr. Farooq, also covers that question.
But I think cardio and brisk walk are the best exercises.
Okay. I'm not seeing any other questions. Just keep on posting any questions if you have any. Otherwise, we can move forward. I'll wait for a moment. Okay, it looks like we don't have any more questions. Okay, so in the meantime, okay, people are thanking you. Oh, there's another question. What are some expected side effects of chemo?
Yes. So the main one, because as I mentioned that especially in patients who have early stage cancer, again, if you have stage 1, stage 2, usually you don't need any chemotherapy. But if you have stage 3 cancer, that's where the chemo comes. And usually, as I mentioned, the chemo is a combination of 5-FU or Xeloda, which is basically the same drug in IV form or PO form. It can cause GI side effect like nausea, vomiting, diarrhea. Rarely, it can cause a little bit of vasospasm in the coronary vessels. It can cause some chest pain, which is not happening from MI, but the F5FU or Xeloda by itself can cause sometimes some chest discomfort. But again, if you have anything like that, it's always a good idea to get tested for any cardiac event. So nausea, vomiting, diarrhea are the major one. Fatigue is a major one, because chemo is a chemical, so which we give in small amount IV. It goes systemic head to toe, and it kills the fast growing cancer cells. So if someone have stage 4 cancer, it will try to kill them. On the other hand, if they have early stage cancer like stage 3, it will try to kill micrometastasis. So basically, chemo will look for fast growing cells, and the fastest growing cells could be cancer cells. So it will kill them, but it will kill our own fast growing cells like hair. inner lining of the mouth, inner lining of the stomach, inner lining of the colon. So it can cause some mucositis. It can cause some nausea by affecting inner lining of the stomach, because these cells are dividing all the time. So they could get impacted from chemo first. Inner lining of the colon, so it can cause some diarrhea. Our bone marrow is making blood all the time, like white cells, red cells, platelets. It can reduce our immunity by reducing our white cells. Usually, depending on chemo, sometimes we give a growth factor shot to boost the white cells. It can bring our red cells down. So it can cause anemia, which will cause fatigue or tiredness. It can bring platelets down. Sometimes it can increase the risk of bleeding, but that risk is not that much. Hair loss, as I mentioned, because hairs are dividing all the time, so it can impact that. Nails get affected. The color of the nails could change. But the major one, I would say that we have to keep an eye for infection, especially with a low immune system. If you have a fever when you're on chemotherapy, it's always a good idea to go to the hospital, because you could be having some bacteria in the blood, infection or sepsis. I think the most common one, or the most painful one, which we deal with in colon cancer is the drug called oxaliplatin, which we use in most colon cancer patients, especially if we don't have any other good option there. And that causes numbness and neuropathy, and that could be very painful. We have a different, maneuvers or pills which we can use to reduce that numbness and neuropathy, which comes with oxaliplatin. But if patients remember, one side effect from their chemo for colorectal cancer is usually numbness in the hands and feet, and a lot of it could be temporary, it could go away. A lot of it could be acute, and a lot of it could be, some of it could be chronic as well, which means that even afterwards, after you finish 3 months of chemo, or even 6 months later, you could have some numbness. But as the time passes, usually that numbness and neuropathy improves as well. So these were the major ones. But again, there are some rare side effects for those other biological therapies, which I mentioned. But for the chemo, these are the major ones.
All right. And another question, what chemo medications are usually used to treat colon cancer?
So if you look at one of the slides, if you get that slides from them, there's one slide which is basically on this topic. So it will mention the name of those chemo drugs, like 5-FU, Zeloda, oxaliplatin, irinotecan, and Lonsurf. So those are like 4 or 5 chemo drugs. And it will also kind of list 6, 7, 8 other types of drugs which are not chemo, but they're used for colorectal cancer, depending on if you have any particular mutation. So there's a slide on it. I think I would recommend to try to get that slide from this presentation.
Okay. And I think that was our last question. I posted in the chat what I mentioned previously about this program being recorded, and that we will post it on the library's YouTube channel. You will also be able to find a link on the library's calendar of events post for this program, and we'll try to send out the video link to all attendees for tonight. And let's see. One last question, Dr. Farooq, is that okay?
Sure.
Okay. Does cold therapy help with the neuropathy? And that will be the final question.
Yes, it does. So again, I would suggest if someone is going through a colorectal cancer treatment, especially oxaliplatin, they should talk to their oncologist to see if they can use that special cap to reduce the hair loss during chemotherapy when they're going through the chemo push, and also the cold therapy to help reduce the numbness and neuropathy in hands and feet. So definitely talk to your oncologist when you go through the treatment.
Okay, I'm just putting up the link for people to get to the library's YouTube channel in the chat. And that's it for tonight for the Q&A and for our program, Understanding Colon Cancer with Dr. Aamer Farooq. Thank you so much, Dr. Farooq, for giving us this wonderful presentation, and look forward to working with you again.
Thank you so much. Thanks a lot.
Thank you, everyone.